We're here for ecancertv at a meeting in Madrid where we've been discussing mantle cell lymphoma, how it's managed across Europe, some of the controversies around treatment, and then some emphasis on some of the newer drugs that are likely to influence massively the way we treat patients in the future. And perhaps I could start off, if we start with the management of younger patients. I think it's fair to say that for the majority of younger patients across Europe, we're talking about cytarabine-based therapy. Did you perceive any differences in the way people were managing that across Europe?
So I think right now RSC-containing regimen are quite popular in the most part of the European country concerning its role in induction treatment for young patients with mantle cell lymphoma before to go to the consolidation with autologous marrow transplantation. And it's quite strange because RSC, as you know, is a very old drug, but anyway, this drug came back and there was a demonstration in several trials that is very active and is more active than CHOP plus rituximab. And for this reason, I think the future will be RSC-containing regimen plus rituximab in induction treatment.
It was interesting, in this meeting we had very lively discussion that everybody agrees that RSC-containing regimen is important, the key drugs for the treatment of mantle cell lymphoma. But I think one open issue about, for instance, the dose of RSC, because we have several schemes in which the dose of RSC ranged between 1 gram meter square for 2 doses up to several days, or even at lower doses, it appears that it's working, it's a good drug. So we do not have probably data regarding what is the exact dose of RSC. We just know that RSC is effective and we have to use it in young patients, of course, but with a wide range of doses. So.
What about the drugs you add to it? I mean, that's the issue for me. RSC is clearly the drug,
yeah.
But things that we add to it, if we add lots of drugs, some of them just give you toxicity. I mean, what do we think should be added to it? What's the key components?
For RSC? Well, rituximab, of course. It's you have to add rituximab, and we had some good experience with addition of bendamustine with intermediate dose of RSC that can improve the efficacy of both drugs. Also because there are some good data in vitro that bendamustine and RSC are synergistic in mantle cell lines. This could be a reasonable combination option. Another combination option could be the addition of bortezomib with RSC. There are some data again with the intermediate dose of RSC and bortezomib and dexamethasone that appears to be effective in mantle cell, in the relapse setting of mantle cell lymphoma.
It should be noted that in most, but not all, historical studies with intermediate to high dose cytarabine in mantle cell lymphoma, anthracyclines are as well part of the combination, but there are some notable exceptions, as you may perhaps describe better than us, because you have developed some of those alternatives.
That's one of the issues to me, whether you actually need CHOP within that induction for a young patient or not.
Because the randomized study are suggesting that alternating or combining CHOP or CHOP-like regimen, like in the hyper-CVAD regimen, with cytarabine is important, but maybe this is worthwhile further exam.
Yeah, anyway, Emanuele, there are several interesting data from the French group concerning the real role of an RSC-containing regimen without any kind of CHOP in induction. This is very active. So I think this is very important for the future also to avoid the anthracycline toxicity for the patients.
And this may bring more elderly people to active frontline regimen if you move away from anthracycline. This is another concept that should be properly explored. there is a second issue important with the cytarabine is that a regimen containing properly dosed cytarabine are also indirectly providing CNS prophylaxis, which might be an issue especially in young patients. Many, but not all the studies for frontline treatment in younger patients combined high-dose cytarabine with anthracycline. And I think it is a major issue whether or not we really need to add anthracycline to the regimen. And if you avoid anthracycline, you may give probably an aggressive regimen also to some elderly people who otherwise would not get it. And there is another point for discussing the role of cytarabine, which is that high-dose cytarabine containing regimens are providing an additional CNS prophylaxis, which might be important, at least in a subset of patients.
It's true. So I think generally there was agreement, you need cytarabine, you follow that up with an autologous transplant, you can argue what you add to the cytarabine, and I guess that's going to be an ongoing issue, but some trials, I guess, with time are going to clarify that. So there's quite a lot of discussion about allogeneic transplantation, which I think we all agree is a minute number of patients actually in the reality of mantle cell lymphoma. I think most people are still of the view that in a young patient, and we can define what we mean by young patient, who's got a rapid relapse after frontline therapy, then an allograft remains probably what we should be aspiring to do. Although transplant-related mortality is high, you could argue whether you cure many people at all doing that, but that still remains pretty much what people are wanting to do.
Well, you know, the transplant-related mortality is a big issue, as you know, and the retrospective data lumped together patient transplant in second line or in fourth, fifth line, so the transplant-related mortality will of course increase if you transplant the patient in an advanced stage. And I believe that in the young patient who relapse with mantle cell lymphoma after autologous stem cell transplant, so far allogeneic transplant is the only proved curative treatment, accepting relapse mortality that is about 15 to maximum 20%. I don't think that it exceeds this rate. And the other point that now we have different drugs that can be used as a bridge to allogeneic transplant without avoiding, the burden of additional chemotherapy. New drugs, biological drugs that can be used just as a bridge to transplant. And so the patient may be put to the transplant in a better performance status, a better condition.
So let's just explore that a little bit. And we're talking about ibrutinib because there isn't really anything else that we've got close to being in that situation. So do you see ibrutinib becoming the bridge to transplant a bit like brentuximab is in Hodgkin's disease right now? Do you see that as an area where that's going to evolve?
Well, I think that it's
very early, obviously.
Yes, it's an early discussion, but I believe that it would be ibrutinib could allow us to increase the number of patients that could be benefit. Young patients, of course, could be benefit from allogeneic transplant. On the other hand, we know that you can get CR with ibrutinib. That it was impossible before that in relapse setting probably, and so you may face the dilemma about in a patient in CR with a biological drug that is doing well, that without symptoms,
the same dilemma
to face the risk of allogeneic transplant. But mantle cell usually relapse even. So
also Hodgkin lymphoma, so it depends. It's a very important dilemma because if you obtain a CR with ibrutinib, what to do for this patient? Allo? But there is a risk of mortality related to the allotransplant. So it's so difficult. You have to discuss with the patients and sometimes a really difficult situation. So.
But do you think we're in a situation now, so you've got a relapse patient now, would you be comfortable giving ibrutinib rather than DHAP or some other salvage regimen to get the patient up for a transplant?
Well, it depends on several things. The age of the patient, the duration of previous remission, and of course in a truly chemo-resistant disease, ibrutinib and also the other several novel biological agents may be an opportunity to get a complete remission and therefore to be allotransplanted with some chances of long-term survival in a setting where before you couldn't even reach an adequate situation for transplanting. But on the other side, you may say that we can prolong survival without a risky option. And this is, unfortunately, something I think no study will ever explore.
No. And it's going to be very much driven by patient choice, isn't it?
Yeah, but there's another point that we are talking about young patients that are candidate for allo, so this patient has already received high dose of C, autologous stem cell transplant, so he had very low opportunities, so ibrutinib, of course, it's a good opportunities, but I would think about always to as a bridge to transplantation. You may.
Yeah, anyway,
I mean, you can use also ibrutinib as a maintenance after allo, maybe.
Sure, but
maybe we don't have any data so far.
Anyway,
but,
you can find a patient that is difficult to convince to do that because he's in CR with a good quality of life.
Feels great.
It's difficult to convince the patient
also
to
the
do.
patient in CR with ibrutinib relapse based on the data that we have so
I know,
far.
we know, but at the same time, at that time, for the patients, it's different. It's a different situation. It's in CR with a good quality of life, and to do a therapeutic option with a high risk, or at least 20% of risk of mortality related to the transplant could be a problem.
Yeah, no, I think it's an ongoing problem, isn't
Yeah.
it? So if we move from young patients to old patients, which is the majority of patients,
Yes.
of course, should we touch on watch and wait? I mean, I know I always go on about this. In asymptomatic patients, now we accept that there's an indolent subgroup. We can't define it biologically. Clinically, they are more likely to be leukemic, splenomegaly patients. But there's no marker that we've got yet that actually gives us reassurance that this is an indolent patient. So my practice has been to watch and wait, very much along the lines of follicular lymphoma. And there's a variety of opinions. Mine's the minority view, I accept that. But do most people think that's a reasonable thing to do, and certainly with low volume disease?
I think I agree with you, Simon. I think in elderly patient is a good option at the beginning to watch and wait and to see in the first 3-6 months what's changing in terms of clinical presentation and so on. And I think you have to decide patient by patient. Anyway, there are interesting data concerning the role of bendamustine plus rituximab in elderly patients. But I think at the beginning could be important to watch and wait and to see what to do for the different presentation of the disease.
Yeah, I think that the point is that we don't have a good marker to identify indolent. I mean, we have two clear-cut group of patients. Clear indolent, I mean, patient with leukemic, no lymph nodes, and maybe spleen, and or patient with bulky disease, extensive abdominal thorax on the lymph nodes involvement. They need treatment. But there are an intermediate group of patients with small lymph nodes, asymptomatics, and I think that in this group of patients, probably you are right that you may watch and wait for a while, and because you learn in 3 to 4 months to 5 months if they need treatment. because in the mantle cell lymphoma, usually if they need treatment, they progress quite early in a few months.
Right, that's also our experience. That, differently from follicular lymphoma, where there is a substantial portion of patients who can remain for a very long time without therapy. Usually more than half of, if not 1/3 of mantle cell lymphoma initially managed with an observation-only policy would need therapy within 3 to 4 months. And so it's an option, but it is really not the same issue as it may be in CLL or follicular lymphoma.
Now, we discussed what treatments people use across Europe for frontline for elderly patients, and broadly speaking, it's R-CHOP or R-bendamustine, depending on reimbursement, availability. One thing, and I want to ask you this, one thing we didn't touch on, and in Switzerland you do this a lot, is single-agent rituximab. Do you see a role for single-agent rituximab in mantle cell, perhaps with low-volume disease, as you do with follicular lymphoma?
We did it in a clinical study, and there was some benefit in using 8 doses instead of 4 doses of rituximab. The benefit had, however, a magnitude which was inferior to the one observed in follicular lymphoma. Nevertheless, in an elderly patient with a non-curable disease, this non-toxic and friendly approach may have a role.
Yeah. Well, one of the things I want to discuss with particularly you two guys is the back regimen, the R-back regimen, because I've used that in relapse in a few patients now, and I've been very impressed with it. You're now using this front line increasingly for elderly, fitter elderly patients.
Yeah, for fit elderly patients, we are using R-back. It's a combination of bendamustine plus intermediate dose of RC and, of course, rituximab. It's very active, and in untreated patients is very safe in terms of hematological and less hematological toxicity. In particular, if you reduce the dose of RC from 800 milligram per meter square to 500 milligram per meter square. So it's active, and is, as I said before, Umberto, there is a good in vitro rationale concerning the synergistic activity between RC and bendamustine. So it's active and with a good safety profile.
Yes, I think that, but you have to carefully monitor the patient because, of course, the myelotoxicity is increased. But in our experience, there is with GCSF support, and there's no increase in infection rates, so this is important. Of course, you need a fit patient, able to cooperate with the centers, but the preliminary data that we have in untreated patients are very, very impressive because almost 90% of the patients responded, the majority of them at the CR.
Because part of the discussion we had was about how RSC is clearly the drug in young patients, and yet we haven't really adopted it in older patients, and that's probably because we don't know how to use it, what the right dose is, what the right schedule is. Yeah. And perhaps this is an insight into how we might be adapting things, because whilst CHOP is fine, CHOP is not the best, and maybe using a cytarabine-based schedule, lower doses, bendamustine, different ways.
According to the different subset of patients, from high dose to low dose.
Yeah. So that's something we need to think about. Now, and then we've got CHOP and we've got bendamustine. What do you think about the relevance of progression-free survival as an endpoint when we're talking to our patients about which are the better treatments? Our bendamustine's got a better progression-free survival than our CHOP. It's got a better toxicity profile, no survival benefits. What do you think about progression-free survival as the endpoint of choice, if you like?
Well, it's a long debate about PFS or overall survival, also in indolent lymphoma and follicular lymphoma.
That's why I asked the question.
I believe that progression-free survival is a good endpoint because I think that the patient wants to, of course, to be alive, but also without disease, without the need of additional treatment. And it's important for the patient, I think, to with the mantle cell lymphoma or other type of incurable disease, the quality of life may be 5 years, 6 years, 4 years, but it's important just to have a good quality of life. That it means to have less amount of chemotherapy or less amount of treatment. So fact, the PFS, it's a reasonable and a good endpoint to evaluate the efficacy of a treatment or any of the drugs.
When we move from clinical trials, where we need precise measuration of the benefit, to the real life, probably symptom-free survival is more important than any progression-free survival.
It's less precise.
Including fit and unfit patients. So anyway, progression-free survival, I think, is the best.
Yes, but as an endpoint, it assumes that you have to schedule restaging, which without symptoms may not be really needed. In the real life, in the elderly population, which is the majority of our mantle cell lymphoma patients, to have a symptom control and no need of further therapy is a very practical goal.
Yeah. The other thing to say is we talked about CHOP, bendamustine, and it was interesting who used maintenance and who didn't use maintenance, particularly after bendamustine. We know there isn't any evidence yet for maintenance after bendamustine, and that was purely dependent on reimbursement, and there was a difference across the countries.
Different countries.
I think people want to use maintenance. There's a belief that it probably is beneficial, but I was surprised how many countries it wasn't available. I assumed, because I came from the UK, we were the only place where that happened, but that's clearly not the case. And then the next thing was you'll use one combination, then you'll probably use another one, accepting that you might use an Ara-C-containing regimen. And then we get into what do you do next. And we've got 4 licensed drugs in the world now, mantle cell lymphoma, and they seem to be, they're different. How do you think those are going to evolve? Well, let's talk about ibrutinib. I mean, that's the most important drug, I guess. Where do you think that's going to place itself, assuming that it's reimbursed? Where are people going to be using this drug? You could say everywhere, but
so you have to start from the beginning. So the data concerning the role of ibrutinib as a single agent in relapsed refractory mantle cell lymphoma are really unbelievable if you compare with the other single agent like lenalidomide, bortezomib, or temsirolimus. And 70% overall response rate, more than 20% of CR rate, with a very interesting median progression-free survival, and this oral formulation, and I think this is very important steps for relapsed refractory patients. Also, in particular, as we discussed before, concerning the role of ibrutinib as a bridge for the allo for the young patients. Anyway, now on the basis of this data, we started with several new combinations using ibrutinib with the other agent like BR, with CHOP and so on, with lenalidomide, with rituximab, but so far it's so difficult to really understand the real role of ibrutinib in combination with other regimen or agents for the future, but we need at least 2-3 years to really understand. Anyway, it's so easy to use ibrutinib in combination with other drug, independently by the toxicity of the other combination, because it's without any kind of cumulative toxicity, and also could be interesting to use ibrutinib also in the maintenance treatment. It could be an interesting solution in combination with rituximab, or as a single agent also in maintenance treatment after the induction phase.
Yes, I agree, but I think we have to think that the data that we have with the ibrutinib single agent are very good in relapsed or refractory patient. So before moving to a combination, we need probably more robust biological data about the combination. Not to pick up by chance a companion of the ibrutinib, but just to choose the companion based on biological evidence, on biological rationale that is
but sometimes it's not
and it's not easy, I know, but also it's important not to have toxicity, because the Brutonib single agent is very good safety profile, and so of course you may add another agent. You can add toxicity, of course, without increasing efficacy. So I agree that we need to move also in combination regimen, but I would prefer to have first at least some biological basis how to combine.
That is, of course, but at the end of the day, it's an oral formulation without any kind of cumulative toxicity. It's quite easy to combine, of course, with a good pathobiological rationale with other agents.
I mean, it seemed to me that people fall into two camps almost, that you've got a drug that looks really good, why add things to it?
Yeah,
and on the other hand, you've got it's not, you're not getting CRs in everybody, why don't we add things to make it better? But then you'll add toxicity. I mean, where do you stand on that?
The Brutonib story is quite interesting, because in mantle cell lymphoma we had several pathways which have been well described and recognized as important for lymphoma progression, and ibrutinib is addressing a pathway which is not among those considered to be relevant for mantle cell lymphoma. And this is something curious. The only biological rationale is that somehow BTK is correlated with SIC, which is a mantle cell associated potential target. But at the end we have the most effective single agent, which is